Accurx is a platform many of us know and love and use almost on a daily basis. But can you get the most out of it? Do you get the most out of it? Well, we're going to help answer those two questions for you in this session as the team from Accurx help us to understand the full breadth of the content that they have, and more importantly, how you as an individual, as a practice, and as a team get the best out of it to save you and your patients some time. So let's take a hand to your primary care and learning. Hello, GP learners, and welcome to this live stream where I'm joined by Dave from Accurx, who's going to be talking to us about basically, easiest way to summarize it, advanced tips of how to use Accurx and the full functionality that exists within the platform that hopefully help you, your practice, and your patients. But how are we doing there, Dave?
Yeah, great. Thanks for having me back on again.
No, definitely. It's been a great session. Previously, we did this about a month ago where we got to see kind of a lot of the content that Accurx have, and we did that obviously live from Accurx. So if you do want to have a look at that episode, check the show notes. The links to that are down below. And we're going to be doing this again in a month's time where we're going to be looking at what's coming next from Accurx. So definitely make sure you join us on the 29th of March, and we'll signpost you towards that at the end of this session. But today we're talking about advanced kind of tools and tips and stuff within Accurx that you can get the full kind of use out of it and stuff. So tell us about it, Dave.
So what we're going to do today is look at all the things we talked about and how do you use them in practice to optimize your workflow, get some time back, and most importantly this time of year, get some quaff back.
Cool. So I think we've got some content to share. So shall I bring that up for you right now?
Yeah, please, let's go. Great, thanks so much. So I'll lead off. We're going to be talking about practice workflow because our product suite is something that as we talked about last time, you can use as an integrated tool set. And we're going to look at how you can, across a practice, make the most of it, make your day better, make life a lot easier. A lot of this I'm going to talk about is based upon things I've done. So just a little bit about my practice. So we're a practice in Surrey. We had remote consulting that moved over in 2018. Largest practice, 11,500 patients, and it wasn't a disaster. So we did this pre-pandemic, had patient survey scores up. We actually had safety incidents go down. Staff satisfaction went up. And I've included a quote from one of our GPs who joined us last year. He said that they keep pinching themselves and they're waiting for the catch. So there isn't one. So if you do use these tools, you can make life a lot better for both you and your colleagues. All tools are how you use them. It's no good or bad tool. It's what you do with it. So today we're going to look at how you do it and what makes your life better. The first thing I wanted to talk about really was what are we aiming for with this? So people talk about different things with online consulting and remote consulting. And this is the day that I think GPs should have. And in fact, the GPs in my practice do have. So using all these tools, we've managed to cap at 25 appointments a day. We aren't turning people away. So those appointments are for our sort of quote unquote routine GPs who are not running the duty list. I prefer to call it, the remote consulting list, but we'll go duty just because it's the easiest term. No extras with that. Visits happen within those sessions. The appointments are all 15 minutes. More complex things are booked in as 30 minutes, so merging two together. So overall, they have an extremely measured, easy day comparatively where they can actually practice as a proper GP. And the only way that we've managed to do this is by using technology well to get time back, to get our days back. The GT doc today is actually much better than it used to be. So we call it GP in charge. And it's kind of more of a team effort where we have live case sharing, which we'll talk about in a second. Open doors, people coming in and out, and actually no longer being stuck in rooms on our own, not talking to each other. So dramatically different. And this is something that you would think a technology like remote consulting, where people talk about it being impersonal and not friendly, has actually opened up doors for more personalized care, better interaction between colleagues, and a more satisfactory day. One of the things that people say is like, why change? Shouldn't we just stay with what works? And I totally get it, because the early pandemic, as this was rolled out at speed, essentially people were given tools, no real instruction manual for them, told to get on with it and hope that they could do the best with them. the reason why I think this is important to talk about maximizing all these ways of working, the technologies we have, not replacing us, augmenting us, is there's just not enough of us, and we know that. So numbers are going down, patient demands are going up. We can't just keep working harder and harder. And the thing that we're missing, the commodity, is time. So productivity gains in healthcare are really hard to do. Banking is great at this. So banking have made productivity gains because computers do what computers are good for. You don't pay a check in with a person over a counter anymore. You do it with a computer, and we're all happy with that. And the reason is because the people who are still working, so interestingly, numbers working in banks haven't really gone down. They're doing more complicated things. So they're helping you pick the right ISA, the right mortgage, and taking on more complicated tasks. And that's where I think healthcare is now. If we make that, then we can actually do the proper care. So I think if we reflect back a few years, I don't think many GPs would have felt they were doing a proper job. We were surviving, and we shouldn't be surviving. We should be thriving. We should be enjoying our job. And the knock-on effect of actually getting on top of this, because most people think of this as an acute-led system, as in remote consulting, online consulting, that's for people who are poorly on the day, etc. If you do it in different ways, and we'll cover it, is you can actually do the long-term condition care better. You can get it targeted, and importantly, manage to maintain your practice income and your QOF. So let's get into what we're talking about. So this is what I would call the current model. So that's meant to be a funnel in the middle. It's not the easiest thing to draw in Google Slides, but bear with me, that is the funnel. And what it represents is patient journeys through a practice. So the sizes are proportional. So this is what we do currently, or most people do currently, I would say. About 75% of time when we start to look at it is with GP or admin time. So I say GPs in general practice. That's with people ringing into reception, appointments being manually booked, administrators doing administration, GPs taking histories, GPs booking follow-up appointments, and spending time with patients. Very little of that time is actually spent by the patient. So there's huge amounts of time invested from a practice to make an appointment happen, to make a consultation happen, and to make a diagnosis happen. And that's great, but we're not time rich. So in days gone by, we were relatively time rich. We aren't anymore. And patients spend a very small amount of their time engaging with a practice. I appreciate people might argue about spending time on the phone trying to get hold of us, but that's clearly what we're trying to avoid with this sort of working. And actually, we can change that completely. So I call it adaptive care. So this is a way of working where we can flex around the needs of the patient by doing things asynchronously largely. I'll cover about why that makes a difference to people who can't use technologies, so we don't have digital inequality, but we're going to concentrate on what does it mean if you do this differently in the first instance. So our practice entry point at this point is now a unified way of all practice workload coming into one place. So this is for within patient triage. This is the patient triage work list. And actually, as it comes in, there's an assessment. So rather than having there be a straight booking into an appointment or similar, so what I mean by that, those are things like appointments where there may be a GT doctor appointment, they may be a phone appointment as a routine, they may be a first contact physio, you get the picture, but there's actually a pause to look at, should we be doing some data gathering? We all learned in med school, 90% of the diagnosis comes from history. Now, from a lot of what we're doing at the moment, it's repetitive, minor illness. You can argue whether or not that's actually general practice's role, but for better or worse, it is at the moment. And actually, that's not so complex to gather data for. Histories are repetitive. Histories are the same in terms of the questions you need to ask. So why do we do that in a manual way? Why do we do that on a phone as a GT doctor list? So, I've seen your tweets on a GT for yourself when you're doing, 60, 70 phone calls on a GT morning. And how well is that 70th phone call conducted compared to the first phone call? No one's fault, really. The nice thing about a computer doing this is it will ask the same question every single time without fail, never be a flaw. And it's quicker for the patients because actually completing full questions is extremely quick process. And then when we start to look at this, and this is data I pulled from my practice, the time that we spend gathering data before the output of this patient needs an appointment, this patient needs a blood test, 75% of it or so is the patient's time. 25% of it is that now the general practice time, which is, and we can use that time differently. So that's actually with someone who can plan care, start to think about complexities, look through notes. I think anyone who's listening to this, who's ever done a duty day, what's our notes appraisal when we're actually looking at a duty list? Do we spend time going back through letters? Do we spend time going back through past diagnosis? Not as well as we could do, and that's just because of that time inequality that we currently have. And so with this, where we have a time shift onto the patient load, then we do get that time back to do that. So what does that look like as we do it? Managing the day is kind of what this is all about. So we can talk about theory, but the practicalities of it is extremely important. This is not a be all and end all guide. This is what we do at my practice, and this is what I think most people could gain some time from, but you can adapt this as you need to. The first thing I want to start with is custom floor rebuilds, because we touched on this last time about the custom floor rebuilder. Custom floor rebuilds is, and any similar way that you wish to do this, is where it's at. So this is really about having an asynchronous, so patient spending the time without you being in a direct one-to-one conversation with them, answering questions that you judge to be important, with answers that you judge to be clinically relevant, and importantly, with SNOMED codes that make a difference to your practice data and subsequently your QOF. This is with the single biggest way that you're going to make a difference to your manual workflows. So, and a very simple example, a common condition, urinary tract infections. There is a very specific set number of questions that you need to ask people who are presenting with urinary tract symptoms to decide if that's something that can be cared for themselves, if that's something that can be prescribed for, if that's something that needs further investigation or face-to-face with a clinician. They never change. So why are we doing that ourselves? A UTI flory takes a patient approximately 60 seconds to complete. From the clinician point of view, it takes less than 5 seconds to send it to them, and then you've actually got most of your answers and you can make that clinical appraisal. All of that's collated into the records, all of that's collated into your EPR, so things like hematuria recorded appropriately, symptoms are recorded appropriately, and then later on we'll come on to how does that give you the chance to work at scale with batches of batch flories. And this is the bit where we really can make some difference to complex care. Massive autonomy and flexibility for practices. The second tool that we're going to cover in terms of how this can make a difference to your practice is Self-Book. So again, we touched on this last time, a practice-initiated single-use booking link that is fully integrated with your appointment book. This can be used in multiple workflows, but we're talking at the moment about that duty day, for want of a word. And now that we have the ability to book on the day with Self-Book, you can actually get to the point where that output of that second funnel that we talked about is no longer having to bounce a message back to reception saying, could you do this? Could you do that? We've got to bear in mind, it's not just clinician time, it's administrative support time. So each time that's one of our practice members spends time doing something that a computer could do a lot faster and a lot more efficiently, it's time they're not spending doing something to support you. So if I ask my patient services team to ring a patient who I could send a Self-Book message to get them into an acute care appointment that day, they're not doing something like ringing someone who's complex and frail and actually needs some support and direction to services that might help them. Where does this live? And this is the crux of most of what we're talking about with day-to-day work. So I've mentored quite a lot of practices now. I think we're probably well into the hundreds about how do you get this working. And the common things I hear is, yeah, but we do this, we talk about this, we use Self-Book, we use flories. So what's different about it? And most of this is a behavior change for people. So what we're looking at here is the patient triage inbox. So what happens here is one of the most important bits about what we're going to talk about today. So this is the point of opportunity that is generally lost, I would say, in most of the practices that I've been to and helped to try and make more efficient. What generally happens, and this is a broad sweeping generalization, I admit, and not everyone on the call would be experiencing this, is these are often handled by administrative teams and they're booked onto a duty doctor list. So that inbound portal with all its efficiencies, with all the opportunities to do all sorts of clever things, then ends up as an appointment within the EPR. So I think most people would recognize that from a duty doctor day. Would you yourself? Does that sound something that happens? Yeah.
Yeah,
And
pretty
I think
much.
a lot of people would. Now, what happens at that point when people start to have appointments on that EPR? What do they not do? I can tell you what they don't do is that they generally don't start to have an asynchronous conversation with patients, and people revert to type, which is generally phoning people, because actually, cognitively, it's quite hard if you are running both a list on your EPR and a list with inpatient triage, which so you've got inbound messages coming in. So people will generally default to one or the other. So the only problem is if you default to the EPR setting, so I'm going to work my way down this duty list, vast majority of people make one of two decisions, which is I'm going to call this patient or they're going to get booked into something. And there's very little of that data gathering. So you've lost a couple of opportunity points. First of all, the opportunity to potentially resolve this without actually having the phone picked up with asynchronous data gathering for simple conditions, sore throats, UTIs, back pains, etc. And then you've also lost the opportunity that if they do need to come in for an appointment, you've not had any data gathering for the person who needs to see them subsequently. So for that person, who it might be a complicated patient, it might be something where you actually need to see someone who's had multiple different investigations, the opportunity to work out what's going on in a way that you choose fit, because you can do this in a customizable way, has gone. So I know I'm laboring the point on where do you do that decision-making process, but for any clinical system that's an online consulting platform, when people start to move it into EPR in terms of appointments for the very first clinician contact, there's an opportunity cost because the vast majority of people then won't use the rest of the tool set. I could bore you with the numbers of practices where I've looked at this and looked at their use of those features, even if they're using patient triage, and I can always tell just from numbers who are booking into EPR, who are handling things here. It's a different way of working, and you have to have some structure to that clearly, and it means that clinicians have to be confident that they're using these tools, but it's the major point that I would say today. Is that making sense so far?
Yep.
Great. So what are we talking about? Well, we call these flows. So these are those opportunity moments that I talked about. So a triage flow, and again, triage is maybe not the best word because we'd like to think about it as remote consulting. But those green boxes that you can see there are decision points where computers can be doing something that a human being shouldn't be doing, in my opinion. Clearly, there are opportunities where you can't do that, where people need a phone call, and that's fine. This is not something that we're saying you need to change your internal workflows. It's not telling you who should do this. It's not telling you how you should do this. But it's just saying at these points, all of these things could be something that could happen with a computer. So sort of moving as we go from left to right, an inbound request of either a phone call or an online request, essentially at that point, look at working within that workflow. We're in the triage inbox now. Have we got enough information to make a decision about this? If we don't, there's ways to do that. We've got Flories. We've got even plain SMS messages with patient replies. If we get to a point where we think, actually, we've got enough information to make decisions, this person needs to come in, you've got self-books now, or you could conclude the care if you've managed to prescribe something for them. And then through all of this, there's moments where you don't need to have human beings doing that. Now, the time saving is astronomical because all of those things take time, all of those things add up. So if you start to do, and I would encourage anyone to do this, if you map out your day the number of moments that you're doing this as a manual, synchronous way of consulting with a patient or booking something, you'll be amazed at how many hours that adds up to. And that's the bit where clinical time can be brought back, because we have no other way of making productivity gains within primary care. We just have to see people sometimes. We have to be in the room with them. We have to sit and examine them. So how do we make that productive? You can't work faster when you're doing that, but you can do a lot of the run up to that in a more efficient way. And some of those things that don't need to come in, again, you don't necessarily need to do them in a synchronous way that takes your time away. This is a really good example of a triage time saving set that I sometimes clinicians don't do particularly well, me included, if I was ringing people about a common presenting problem, which is back pain. So I think I did a quick run through before we did this today of how long would it take me to do a back pain question set to clinical acceptable standard with the person who was ringing in. And it was about 4.5 to 5 minutes to get the information from them, running through this, explaining it, to say, actually, we're really happy that nothing serious is happening, and this is just something that needs a bit of time with the physio, needs some pain relief, etc. The floor-easy version of this to send to someone takes me about 5 to 6 seconds, and then a review of it depends on how quickly you can read. And then after that point, you've done two things. First of all, you've conducted an excellent clinical history of someone with back pain, which is, although common, occasionally related to serious conditions. And you've also standardized this across all your clinicians, because if you're running a practice, one of the things that varies, as people will appreciate, is clinician to clinician, day to day, depending if people are tired, if stuff's going on at home, they're not always going to behave in the same ways. And sometimes bad thing happens as a result. Again, computers are really good at doing that thing repetitively and allowing your clinicians to make decisions based on information that patients are giving you in a structured, clinically verified way. You can use this as you wish, and you can customize this as you wish. But just as an example of these ones, for people who presented in the last 2 years to my practice, there were 2 people simply based on their Florey answers that we picked up an impending cauda equina, and they were both decompressed on the same day. And, you know, I would honestly reflect on that and say that I'm not 100% sure that A, we would have reached them in such an efficient time, and B, I'm not sure all of the questions would have been asked appropriately, because some of the symptoms were slightly subtle and they might have otherwise been missed. You might ask about, okay, what happens to those people who don't actually have the ability to use a computer? And this is where the digital inequality bit is really important. So the reception flow within patient triage is a bit where you can add in things into that same workflow with people who are calling in. So that allows your patient services team, reception, whoever, to have demographics pulled with a simple one-button click within patient triage, and it means that they all get treated the same. And I think that's the most important thing, is working within that system where, you know, appointments are not being booked in different ways. The speed of assessment of either an online presentation or a phone or walk-in is being dealt with differently, means that someone is getting a raw deal as a result of it. If they're all treated the same way, everyone gets a rapid response from the practice, and they get appropriate care, and they're not disadvantaged because they can't use a computer. It's the most common refrain I hear when people talk about this. I think I know this because I checked before we started today. So median time to answer in my practice the phone at the moment, just simply because we've shifted quite a lot of people online. I think it's about 80% of requests come in online now. Not because we've made anyone, it's because it's efficient for them. But it ends up being about 32 seconds for the phone to be picked up in the practice. And I must stress, we don't have oodles of people just sat around waiting to pick up the phone. What it does mean is that for those people who can't use computers, it's got them into a much better place. So all of those things are then booked within the clinical system, history's taken, lots of time saved for reception, lots of time saved for clinicians, and we can absolutely make them into a much more efficient workflow for those people who can't use computers as well. I must apologise, this was a GIF, but was in fact made into a static image as we uploaded it, so apologies. If you are going to do this, though, you want to be using the other bits of the tool sets. And these are the bits that the data geeks like me like to look at, but it's a bit that probably not everyone in every practice is aware that either exists or have used themselves. And this is the practice level dashboard. So why is that important in terms of what you do day to day? Well, I think most practices at the moment would struggle to tell you what is happening day to day, hour to hour. Both EPRs that are in major use, well, I should say there's three, aren't there really, but the two major ones that are in use, it's extraordinarily difficult to extract this information from them, and usually requires a third level product to tell you what happens on each day, who's doing what, and even on the lower image that you can see there, a heat map hour by hour of how many inbound requests, bearing in mind that you're mapping both phones that are coming in and also online requests, means that you can actually appropriately set your staff times, days that they work, that manages demand. It just makes no sense, and you're burning money if you have staff who are working in bits of the week where you're massively overstaffed. And it also means that on those days where you're massively understaffed, and you may not know at the moment, and may just think, oh, it's just a really busy day, that you can actually reallocate things, reallocate people, or shift demand using tools like self-book so that you can actually have a better day. The other opportunity that people never really, to my experience, think about when you start looking at this is gaps for plan care, gaps for QoF. So these are things that, going back to the ideal day that we talked about earlier, like that day that we would aim for, within that, and certainly this is something we do, starting to have appointments within there for review clinics, virtual review clinics, plan care and QoF catch-ups, means that on those lighter spots in that week, so looking at that bottom diagram there, those sort of paler sections where things aren't quite so busy, you can have people doing care that they need to do. And I think if you would talk to most clinicians when they consider, what am I like in terms of doing QoF? Do I do it to like absolute top clinical standard, or do I do it to QoF standard? I think a lot of us would say we probably do it to QoF standard when we're under pressure, and then we do it to good clinical standard when we're not under pressure. So why not plan that? But you can't do that if you don't know what's happening within your practice. Coming in the future, we're going to have some improvements to the patient triage dashboard. So we talked last time that we're making changes to this. So the one that you've just seen is live and exists now. The one that will exist in the very near future will be live data that will show you allocations to each clinician that you've had during the day, how many requests they've had, sorry, I should say clinician and other practice members, and you can plan that based on the requests that they've got. So again, it gives you flexibility about how you wish to run that. So if you have a duty team who are managing that inbound workflow, you can make sure that workload is distributed appropriately, and you can actually get your efficiency up. So on a simple level, if someone's really struggling and having a really hard day, you don't want to start piling more onto them because they're just simply not going to be able to do it and it won't be done well. So this will be there in the very near future, giving you absolute granularity, well, minute by minute, hour by hour, about what you're doing within your practice. No good doing all that if we're doing things that we don't need to do, because we're talking about time that we need to gain back, and there's lots of things that a general practice is asked to do that either is not appropriate for us to do or simply doesn't need our involvement. So we've created self-referral, which, well, not created self-referral the concept, but created self-referral as part of patient triage, which is a customizable link right at the front end, which I'll talk about why that's important, which allows you to put in all your localized self-referral services, so IAPT, physiotherapy, audiology, etc., which means that you can get patients to go there earlier rather than coming to you first. Now, that might sound like low-hanging fruit, but within lots of practice websites, if you wish to take the time to dive into your clicks and where people are clicking within it, though I'm sure you do have this information already. However, it's usually in a place where patients rarely visit, and they often won't use search functions to find it. So the more you make it up front and somewhere that's accessible, so you'll notice where this lives. This is within the first section after you click through to the I would like some help from the practice, however you wish to term it. So the first port of call for the Accurx patient triage system, and it's right there up front, meaning that they can access it straight away. and divert happens before you start to get involved. And that's small time saving, but it is a time saving, and it helps us encourage self-care. The concept of people needing to have information like this at the point that they want help, it is not a new one, but where you put it is quite, I physically mean where you put it on your website is quite important. And having it at the point where they're just about to ask you what to do is a great way of making sure that they're not actually seeing you or contacting you when they don't need to. It wouldn't be this time of year if we didn't talk about how do we use these tools to maintain income. So, we've covered about what's the day, how do you make your day better. Not so good if your practice goes under because you haven't been able to maintain your QOF income. And that's an extremely difficult challenge and has been over the last few years. And I appreciate that there is some significant difference across ICBs who are going to cover off some costs in some areas, and other areas are being left to actually just try and get through QOF as best they can. So why would online consulting make that better? Because although we started to dispel the myth that it increases workload, might increase contacts, but you can certainly use it to decrease your workload with the tools we talked about. But we can also use it to maintain our QOF, and we can do that in a way that keeps you time efficient, practice efficient, and actually enables you to direct care where you need it the most. So this is the batch messaging concept. So I won't go through how do you get people into your practice recall system. Everyone's got their own way of doing it, but if you haven't got a recall system and you haven't got a structured way of following up on people who need an annual review, definitely start to get on top of that, but the vast majority of people do. The concept of this is about fishing out from that large bulk of people who we need to review, those ones who need more significant clinical input than others. Batch messaging allows us to contact large numbers of patients in a very time efficient fashion, and combining that with two tools, which is Flory and Custom Flory and Self-Book, means that you can start to make enormous time savings. So twofold way of doing this. The first thing is that you need to work out who needs what kind of QOF input. So you can start to create in Custom Flories, and soon these will be shareable, QOF validated question sets that allow you to have a disease review, work out what their symptoms are, get your QOF coding, because not forgetting that we get SNOMED codes included in that, and then from that pile of people, pull out the ones who actually need the physical reviews. As a rough rule of thumb, this is across multiple practices that I've done this with, about 60% of people who need an annual recall for any reason, that includes chronic disease, medications reviews, don't actually have anything that needs physical GP input, as in face-to-face input with them, and can often just be signed off because the symptoms are well controlled, or they're on a drug that's not actually particularly important, hay fever, etc. So if we use this and don't have people booking into appointments initially, but start to have this within your the time that you've given back. So remembering the day that we talked about earlier, there are planned care and virtual review appointments. So within our practice, what we do is have a QOF administrator who manages the inbound messages each month and allocates them into those appointments for a clinical review. And then patients can actually be reviewed by a clinician virtually. If they need to come in, self-book messages are sent out to get them into the appropriate appointments. If they need to come in for investigations before they have a clinician review, again, we do batch self-book for them so they can book into phlebotomy appointments or diabetic review appointments. And all of those things happen, meaning that the ones who finally hit our clinicians, as in they're either on the phone or physically sat with them, are the ones who've actually got a problem. So most people will have experience of balefully each year having people sat in front of them who are extremely well and have no problems, and their health is very well controlled, and their diabetes is fantastic, and their asthma is fantastically controlled. And that's because they are the ones that are very much engaged in their own healthcare. So the concept is fish out the people who aren't engaged or not well controlled, pull those into the appointments, the ones that we can offer them because we've made that time back. You get your QOF done, you get better clinical care for patients as well. The hard to hit ones are ones that really benefit from this approach. So again, this is anecdotal because it's my practice, but the number of poorly controlled asthmatics who've been QOF excluded over years, poorly controlled diabetics who've been QOF excluded over years, simply because they won't engage and come in, has absolutely plummeted. So we have nearly 95% engagement in terms of review for all of our long-term conditions now, which is unusual, I think. And that's simply because we offer this as an asynchronous method of reviewing their symptoms. And then the critical bit with things like self-book is that when you send out a message to someone and say, please, could you ring the practice to book an appointment with X, Y, or Z? Often people won't do that because they're busy, they forget, or they can't get through, or they can't get an appointment, etc., etc. Self-book allows you to do that and gives the patient the opportunity to do it there and then. And that's what most people do. I mean, sure, we can all do that. If we don't do something there and then, we forget about it or have to put it into a task list to do later, and patients are no different. The massive thing that I would say is, though, that this is a clinical improvement tool. So the time that people spend with GPs and GP colleagues, practice nurses, paramedics, etc., is based on need, not want. So if we do this, that means that actually those people who are physically sat with us or on the phone are the ones who actually need our help, and we get their care better. So, we've seen a huge improvement in our diabetic numbers just simply because the ones that we're actually pulling in now, the ones that were hard to reach, are the ones that need us. QOF flow is no different to our other flows. So in terms of those opportunities, they're all highlighted in the green bits. They're the product opportunities that you can use. This is completely customizable to your practice. So this is just a thought process map, really. So first of all, you've got to engage your patients and tell them what you're doing. If you're planning to do this, let them know that what you're doing is to actually get them care, not to fob them off, because people do get suspicious about things that are happening remotely if they're not used to it. Make sure that you maximize the face-to-face opportunities. So on this, we talk about, is it a single QOF register or multiple QOF registers? Don't have people being pulled in for multiple different appointments. Send them out all the things that they need in one shot and get them in for their single review appointment, either tests if they need blood tests, etc., or diabetic checks, and then have them reviewed by a clinician once all that's worked up. Again, the time saving is absolutely enormous. So it means that clinicians are spending very little time on people who are well, because they can look through, have all the data at hand and go, yep, you're absolutely fine. And we will at that point let them know that we're happy and doing their review. Just give us a shout if there's a problem. Or they're actually booking them in, again, through self-book for those planned care appointments. So means you can hit QOF really easily. Well, I say easily, but still needs clinical input, but much more easily than chasing people around on the phone. And you can actually improve clinical care, which is what QOF was all about, although it does feel more like a box ticking exercise these days. No good talking about any of this if we don't talk about what happens when people do come in to see us. So why would asynchronous consulting, why would these tools have any difference to people who are physically sat seeing your colleagues once you've actually decided that they need to come in? Well, twofold. The main thing is that gathering appointment information beforehand, so going back to that first contact stage and pulling that data in, makes an enormous difference to clinicians. So our GPs who joined us this year have said that going from essentially like cold appointments where people are coming in with no idea what's happening or very little idea of what's happening, to ones where people are largely worked up in terms of what's happening with them, symptom sets, red flags excluded, all that sort of stuff, investigations, all done, means that when they do have those appointments, they're doing what we're good at, and that's being complex care clinicians. I mean, general practice these days is, a very complicated subject. We're really good at what we do. We're really good at synthesizing information and coming out with diagnoses and plans, but largely we don't have time to get the information to do the reviews of the notes, and this allows you to do that. The second bit is that you can allow follow-up to happen in a much more structured way. So for better or worse in my practice, I tend to look after a lot of the complex mental health patients with serious long-term mental health problems. And I generally will keep tabs on them through, first of all, summarizing what their appointments have been about, because as you might imagine, with chaotic patients, that can be quite difficult for them to understand or follow what's happened, but having digital follow-up. So rather than having lots and lots of time, and I must stress that this is for people who are suitable for it, lots and lots of time with people booked in for the sort of just in case appointments that I think we'd all be familiar with. Digital follow-up with pathways, so these are where we can send scheduled messages or flories to people, means that probably of the list of people that I look after for those conditions, 80% of them at any one time are generally ticking along quite nicely, but happy that I'm checking in on them in a scheduled fashion. And the other ones are not fine, but generally now I'm picking them up a lot earlier and bringing them in for an appointment before crisis rather than when they hit crisis. And that is also something that is applicable across a multitude of different conditions, heart failure, brittle asthmatics, anyone you choose really. So again, this is going fishing upstream for problems before they get really complicated, but it's doing it with computers because computers are really good at doing things repetitively and keeping to time and keeping diaries and making sure that they check in on people, whereas either we're not because we forget, or in fact, it's an extremely time-consuming process because the vast majority of people are well and don't need us to be checking in on them. What are you going to do then? So we talked about some of the tools, what you can do with them, and how that might work in a practice. What would you like to do next? Well, practice planning is individual, but there are some common concepts that I really want to talk about, just so that you can go away from this presentation having gone through all of these tool sets as a unified set of tools. So we've talked about going from start to finish, really the entry point to the practice for acute care and long-term condition care, QOF, follow-up for patients. What's the transformation like if you wish to make it? A slide missing, but nonetheless I can recall it, so no problem. The main thing about practice planning is that you have to make it work for you. So I would choose, what do you want your practice to look like and what do you want your day to look like, and then fit it around that. So when I planned practice transformation for my practice, we worked in reverse. So I said, what would an acceptable day be? And then we worked backwards from there and made it happen with all of these products. So the things that I talked about were things that we came to because the tool sets were there and actually thinking about what we were aiming to achieve, they fitted well with it. But you really have to make sure that that's something that fits for your practice. Digital's great, but the way it was implemented previously, I think over the last few years, and I'm talking on sort of national scale now, was that it was bolted onto general practice. We probably weren't given very good manuals about how to do it. And essentially it was, I think the message from a lot of places, I'm not saying from us, but certainly from Central, was it'll take some pressure off your phone lines and your patients might like it, but they didn't really talk about what you could do to transform your day. So pick what you would like your day to look like, start from there, work backwards and work out how you can make that happen either with your GT team or your triage team. Work backwards and work out how you're going to work out your long-term condition care with a restructure of who's going to review those things, who's going to actually do the implementation of planning, and who's going to do the appointments. And then actually all of that is things that are applicable across all of general practice. So the concepts are universal. The way that you implement the tools is entirely personal. So apologies that the slide that had that data wasn't on there. Thankfully it was in my memory banks. So it's appeared. So that was the slide we were looking for. So that was the end of the run through of our product set, and we were going to take a little pause there, so for some questions and answers. And can I hand back over now?
Definitely, and thank you for that, Dave. So we've had quite a few questions come through, and I've also got some that came through in my head from some of the stuff that you've shown as well. So we've definitely got lots to cover and stuff. I guess I'm going to go through some of these in slightly jumped around order, and particularly start off with Facebook user. Unfortunately, the name hasn't come through because it's the way Facebook works and stuff, and it's a really big question. And it sounds like it's one of our busy colleagues trying to multitask by watching this as well as answering questions and and stuff like that. But effectively, how do you manage the risk of a patient not responding? For example, when you send a self-book link and stuff, in terms of patients not engaging with it, and obviously the fact that SMSs doesn't have read receipts, for example, and stuff. So I think they're asking, is there a way that you can think of that manages some of this? And I guess I'm also going to bolt on to that question, if that's all right. I know that Accurx does have NHS app integration. To what depth and what is that going to look like in terms of notifications and that kind of stuff, in terms of the future and things?
Yeah, it's certainly a good question in terms of a patient safety issue. So first of all, self-book does tell you when people don't book. So it will give you notification. So, and if they've had an unsuccessful attempt to book, so you do get notifications about that. There are delivery receipts for SMS messages, so you can check that. What I would say is though that, and this is a personal thing, depending on the severity of the problem that I'm messaging someone about, if I need to be sure that they've actually received what is a safety critical message, perhaps that will be something I'll do synchronously. I'd ring them up, or someone would be ringing them up for me. Going back to the idea that you're freeing up your patient services or reception team from a lot of administrative tasks, it means they can support you on things like that. So safety critical messages can be delivered synchronously because you've made that time back. I don't think you'll ever eliminate potential risk of people not reading messages, etc. But I would say that in an annual year, I know how many messages I send a year, and I think it's approaching 80,000 that I send personally. And the number of safety incidents that I've had over 5-6 years now is zero. I've never personally had a safety incident as a result of it.
Okay, thank you. I know from my perspective, one of the ones I often do is the 2-week wait ones, and I tend to adjust it slightly. So I send a brief summary in the initial text message, and then send it so that it sends a repeat one in 2 weeks' time, something along the lines of just checking that you've had contact about your appointment that we discussed in the previous one 2 weeks ago. If not, please contact our admin team. So then there's that extra level. And like you say, because it's automated, I don't have to keep that cognitively in my head. And also from the patient's perspective, they get that reminder within that 2-week time frame, which is what they should have had some sort of contact within, as a safety check. And that's definitely one that I've been massively using to try and save time for our admin team, and especially making sure the safety side for patients is just working and things.
Yeah, and that's a really good example. That's a really good example, and speaks to the fact that computers can do the things that we're not good at, remembering stuff. And what you've got to look at as well is what's the current status quo. So what we're comparing it to, and actually, is this perfect now? So we often get digital compared to this fantasy land where everything's perfect, and it isn't, and it isn't perfect now. So much of this is improvement, even if it's not perfect.
So we've got a question then from Cribix that's along the lines of messaging. So read patients not responding. How do we know which patients have proper smartphones and use them versus those that have a Nokia, which they never switch on? I guess that's pretty tricky to do, but I know there is some element that Accurx will tell you if a message has not been delivered, if I remember rightly. Isn't that correct?
Yeah, you do. And I think you're right. There's no physical way of checking if something is a smartphone or not. As we move towards NHS integration and message alerts, then that's going to be a lot better. Essentially, most people will. I mean, even if you've got Nokia, you can get the message. So I think most people practically, if they can't respond to it, end up ringing the practice. So it does happen to us, and that's fine. And we just simply make a note on the patient notes that it's not actually a smartphone response. But that doesn't mean that you can't use it for information imparting. It just means that you're not able to have that two-way conversation.
Okay. Next, we've got a question from Julie Eiley. Currently working on an IIF, so Investment and Impact Fund, wanting to send an ethnicity campaign out to our patients, which automatically recodes back into their notes when the patient replies. There isn't a question there, but I guess the question is, can they do that?
Yep, that's entirely possible with custom flories. You can do that now, and I know that people are doing that. Just as a comment, just be careful that you can't code them at no replies as saying that people have refused, because that means that's not quite the same thing. So just be careful about how you are coding that.
Okay. Wansford S1 has then come up with, I think, batch messaging costs extra, doesn't it? I believe that's correct.
Yep. So depending on what you've procured locally, the modular aspects of these may or may not be available, but they are purchasable on an individual level for a practice. So if you go into the Accurx website, it's got the various costing levels, and you can contact our teams to talk about that. What I would say is cost of that, even if you're procuring, and just for transparency, we procure at my practice, we purchase it. Compared to actually employing the people to do that tasking or those taskings, it's a small cost. And certainly for Quaff as well, some of those tools are minimal costs compared to what you would make back instantaneously on being able to get some of that data back in and fulfilling those Quaff domains.
I think part of the challenge many practices have is obviously they're trying to juggle the cost of a product versus not recognizing the amount of time it may save staff, and that's the hidden cost that you don't see then. So therefore, like you say, it frees up staff because they're not having to spend time doing what people don't often see that they're doing, and therefore that's where you get the gains. And often it's trying to reconcile the cost of what the software or what the the change itself can do for the practice versus just the actual monetary cost itself, which is often what people just look at and stuff, unfortunately.
And that's absolutely true. But this time of year is a really good time of year because you can actually see a real cost benefit because you get your Quaff done.
Absolutely. So once S1 came on with another question, how do we add the self-refer choice? I think this was the self-refer kind of tab that you had. Is there something specific practices have to do to add that in, or does it come through automatically?
So that's something you have to ask to be turned on. I think it's in beta at the moment and is about to be an option for everyone. But I think essentially, if you use our contact the team button on the Accurx homepage, the little green button in the bottom right, you should be able to ask for that to be turned on. We found it very useful.
Cool. My question from that one was, can you actually reorder the so you showed us that patient version of it, and I think it was the self-refer was at the bottom. Can you actually reorder it, and can you also change the text that's in there as well?
Reorder, no, at the moment. Text, yes, you can change the text within it as well. So that's something that you can customize for it.
Yeah, cool. I guess because it said something along the line, use this to self-refer yourself for things like, for example, physiotherapy. As you mentioned, every area may have different kind of things that they can self-refer to, and listing some of those may be more useful to try and, like you say, direct patients to realizing that they can actually self-refer for certain things that they didn't realize and stuff.
Yeah, absolutely. So clearly it would be bonkers for us to have things on there that weren't available in your area because it would make patients very sad. But no, you can customize that text. Can't change the order of the buttons at the moment.
Okay. Further question from Jastua. So I think custom flories are great. Would really love to be able to receive textual data, not only in multiple choice answer. Will this be planned in the future?
Absolutely. So there's a lot of jiggery pokery that goes on behind the scenes to make all this work. So the product that would work straight off the bat was the one that we've got at the moment. So to make the other bits work takes a little bit longer, but absolutely recognize that things like having data fields and free text is a massive bonus, and that is something the team are working really hard to get out as soon as possible.
Mm-hmm. And I know, as you were talking about particularly the benefit of flories, in particular of capturing data, and you talked about that time saving that you have. I guess one of the other things that came apparent to me as well as you're talking about it, one of the things I often do when I pre-screen a patient's record when I'm about to consult with them, particularly if I know what they're coming about, is searching the records for key information. So you mentioned the UTI and the hematuria one, being able to search for hematuria to see if they've ever had it previously, because you're using the flories and you've asked that question and it's coded. Obviously, you can then find that, so you can see if there's previous episodes of hematuria which actually may be more relevant to your clinical decision making. And because that question's already been asked, the information is there, which I think is a really powerful tool that we will see the benefits of as we move forward, and maybe even now, depending on how long you've been using it for and stuff and things.
So coded data is better. So the problem with GP records generally is that it's free text, lots of it. So when you have coded data, it means that you can make your clinical systems do clever things, and they can alert you to problems. So using your example, so if you have UTIs coded properly, it means that you can set up protocols or system on equivalents where it can pop up and say, actually, this person's had the 6th UTI in 3 months. Are you sure you want to be prescribing, or should you be doing something else? Or they previously had hematuria but not been investigated, all sorts of things. But you can't do that without codes. So that's why having computers do some of this, because I can tell you now, GPs are not the best at coding, as I think we'd all probably accept, is a really good way of making your clinical records safer.
Okay. I've got an interesting question again from Cribux. Apologies if I pronounced that wrong, but that's the easiest way I can say that name. How do we reconcile inbox activity with the NHS extracting appointment activity, which is driven by standard appointment slots and appointment mapping? So I know you were talking about this, how people add it onto the EPR and therefore just bash through it on the list. But there is this issue of that if it's not captured on the EPR systems, it may not be captured for GP appointment data, so the GPAD stuff. Does it work? Doesn't it work? Can you talk us through that, Dave?
Yeah, so you're right. So there's the demand from NHS that we map all of this stuff into record, and I'm currently having a personal level, not company level discussion with them about that, because I think it's clearly not the way that we can improve things, and actually lots of areas recognise that. If you want to play by the rules, then you have to have that in your appointment book at some point. The question is, does that need to be the clinician who's doing that initial inbox stuff doing that? Because as I say, there's some behavior change. So if you wanted to have it all mapped into your EPR, what I would be suggesting is that someone else is doing that rather than the clinician themselves, because it's a time consuming process. Clearly I couldn't possibly comment on people not doing that and just simply handling it on the inbox and ignoring NHS England, because that wouldn't be within the rules.
I guess, is there any plans for being able to extract the inbox data into the GPAD system? I know quite a few other providers have been looking at this, and there are some issues with this from particularly NHS Digital, or now NHS England side as well. But do you see that being the way forward?
Yeah, it's technically possible that I think, as you say, for most suppliers, if NHS Digital wanted to extract that, I think most suppliers have offered that. I know we have. So the solution would be there. I'm afraid, as jobbing GPs at the moment, we are just rather stuck in the middle of it with our lords and masters telling us one thing that they want from us, and the people on the ground saying actually that's a very time-consuming way of doing something. So I'm afraid at the moment that isn't something that's been resolved.
Okay. So another question from Jas, I think this follows on from her earlier one. In custom florries, the SNOMED codes are limited. Your own florries have these codes present. Why can't we have these codes made available to us? It's frustrating to not be able to code in this way. And then she used an example later on about how the asthma ACT codes, when you tried to build an enhanced asthma florry, exist but don't exist.
It's just simply because the codes were the ones that were loaded up from the initial build. So as it expands, it's going to have a larger selection of codes, and I think also, and we would need to double check on this, so don't quote this as gospel. I think they may be able to be added if you message the team and ask for that SNOMED code to be added to the list for custom florry, but don't quote that bit as gospel.
Fair enough. So if people do have further questions, please let us know, because we're coming up towards the end of the stream, but would love to get some more in if you can do. Just whilst waiting to see if any do come through. Will's got a rather interesting one. It talks to some of the stuff that you mentioned. So Will Brown, do you find an issue with elder patients or those with learning disabilities not engaging with the tech to support workflows and not responding to things like questionnaires?
No, they're the people that benefit most, really, because they're the ones that I actually fish out, because I know that they can't do that, and then we can actually make the appointments for them. So this is all about like equity, not equality. So those people get equity of service because actually we don't make them do all of this, but they still get priority service because we handle their requests quickly if they phone in or similar, don't send them things that they can't utilize. And actually, because I was talking about those appointments earlier, 15 minutes, for people who have got significant other needs, the clinicians in my practice will get 30, 45 minutes with them as a planned appointment. So again, this is something that how you use it's really important. If you use it just to benefit people who can use tech, it's hopeless and will really disadvantage those people. But if you then leverage all the other bits and pieces, it makes a massive difference to those people, and you can do proper care for them.
I think there's also that aspect, isn't there, of that sometimes even the tech can still help those types of patients. So I know for me, one of the challenges is the patients who don't speak English, because we've got such a high proportion of them. But actually, through text routes, some of those patients, now not all, some, still have the capability of being able to share the information, and more importantly, they spend the time putting down that information so you get a better handle of what the appointment might be around. Yes, you don't have the synchronous back and forth that you would have with an interpreter, but at least you've got more direction in terms of understanding the priority or the focus or even the clinician that person needs to see. So, for example, is it actually the reason they need to come in is for a smear test, or is it because they've got dysmenorrhea, which you can't capture as easily through a triage system if it's just audio, but telephone based and that kind of stuff. Whereas if they have had the opportunity to form some of that, you sometimes do get better information that helps you direct it more effectively. That's one of the things I've found particularly. But again, it is a subset of those patients. It's definitely not applicable to all.
No, absolutely not. And just can I answer on the Snowbag codes for custom flories? Just had to confirm that yes, indeed. Just message and they'll add them for you.
Awesome. So, Dave, we've spent a good hour going through kind of the ways that you can use Accurx more effectively within your team. I know previously in last month's session, we covered kind of the basics of the tools and stuff. Today, we've gone through in a lot more detail as to how you can put that workflow within your practice to make it easier for your team, for yourselves, and absolutely for your patients and stuff. I know that we're going to do this again in a month's time. We're talking about what's coming next from Accurx. Any spoilers you want to give?
You're going to see a product set that's a lot more aligned, easy to use. Things are going to be different in terms of the way it looks. There'll be features that aren't quite ready yet, but we're going to make life a lot easier. And we're also going to cover about what this might look like with working with our secondary care colleagues as well, and how that's going to make life easier for both primary care and patients.
Yay! Definitely like hearing things are going to be better between primary and secondary care interface. So if people do want to join us for that session, that's going to be on March the 29th. If you're watching this on the replay, it may already be there, in which case the links for that will be coming up shortly. Alternately, do subscribe to the channel so you can get access to that as soon as it comes out. So 12:30, March 29th, we're going to be talking about what's coming next from Accurx. And as always, we're here to help try and make tech enhancing primary care and all that kind of stuff easier for you in practice. And we will catch you in the next episode. Wishing you all a great Wednesday. See you later.